Well, it's really a pleasure and an honor to be here tonight and to have the opportunity to share with you our work about the Day One Project, an effort to develop affordable, highly effective technologies to improve newborn survival in the poorest communities in the world. Maria and I are trained as bioengineers, and so we spend a lot of our education and a lot of our early careers thinking about how to innovate new health technologies. And we did that without really thinking explicitly about who would have access to those technologies. I think for both of us and for many of our colleagues, we're really motivated and inspired to improve the health of our children and their generation. These are some of my kids, and I'd like to see them be the first cancer-free generation. I'd like to see them have access to all of the best technologies that can help them have a healthy life expectancy that's longer than that of my generation. But 90% of the world's children live in developing countries. Half of them live on less than $2 a day. And the health challenges that these children face, they're enormous. If you look at the life expectancy of a child born today in Swaziland, it's actually 10 years less than the life expectancy of a child born 20 years ago in Swaziland because of the HIV epidemic. If you look at a little girl born today in Chad, she's only 10% more likely to learn how to read than she is to die before her 5th birthday. Who is innovating technology for these children? If we look at where healthcare resources are being spent to develop new technologies, what we find is that 90% of R&D dollars in healthcare are focused on the health challenges that affect 10% of the world's population. This is known as the 1090 gap. Why does this exist? It's not hard to understand. If you look out the office of the bioengineering department, you see the Texas Medical Center. It's the largest medical center in the world, and you have access to a specialist and a subspecialist in every area of medicine. And if you have health insurance, you have access to every kind of technology imaginable. There are very powerful market incentives for companies to develop technologies to address the health needs of patients who are seen at the Texas Medical Center. And you don't have to worry about infrastructure like electricity and water being present for your technology to work. You don't need to worry about a supply chain for disposable supplies. And you don't need to worry that if something breaks or needs to be calibrated, there might not be anybody there who knows how to do it or who has the spare parts or the tools that they need to make that repair. But if you look at the settings where most of the world gets their health care, that's just not true. The infrastructure that you need to support those technologies doesn't exist. And what are the market incentives to develop technology for this kind of setting? What is the supply chain to get the disposables that you might need or the spare parts that you might need to repair those technologies? This photo was taken at a lab in a health center in the DRC, and it's a very typical laboratory for what you might see in the developing world. There are two pieces of equipment here. There is a light microscope. Because there's no electricity, the microscope is next to the window because the sun is the source of light for this microscope, and there's a hand crank centrifuge. And that's a very typical kind of setting in which people are trying very hard to deliver quality health care, but they just simply don't have the access to innovation that could help them improve health outcomes. And so what do we need to do if we truly want to make healthcare innovation to everyone in the world? Well, I think we need to do three things. I think first, we need to engineer highly effective but affordable health technologies that take this lack of infrastructure into account, that can work in this type of environment. And we need to figure out, how do we get them to these places in ways that can be sustained over time economically? But I think in some ways, most importantly, we need to educate a new generation of leaders that know how to work not only across disciplines, but also across cultures to invent and to deliver the kinds of technologies that can really make a difference in these settings. In thinking about this challenge, we decided to start at an unlikely place, and that's with undergraduates. We partnered with physicians and nurses who were delivering care in the poorest communities in the world, and we asked them to identify what were the biggest obstacles that they faced in delivering care. And we came back to Rice and we turned those into design challenges for our students. From the freshman year to the senior year, we brought them together from all majors across campus, working in teams to try and develop solutions that could work in places that don't have clean water, that don't have electricity, that don't have money for expensive consumables. And over the last 4 years, we've engaged 10% of our undergraduate students in designing these technologies, taking them to the field, getting feedback on them, and trying to get them to the point where they can actually improve care in these settings. And we're very excited tonight to share with you the story of some of these technologies.
One of the first partners that was willing to take a chance and offer design challenges to our students is pictured here. This is Professor Liz Molyneux in the neonatal intensive care unit at Queen Elizabeth Central Hospital in Blantyre, Malawi. When Rebecca and I first visited her hospital in 2007, we were just absolutely inspired by all that they were doing in the environment that they had to provide the best quality health care to the children in that environment, the most vulnerable children, the neonates. If a child is born here in Boston, Massachusetts, or in Houston, Texas, and needs intensive care, they will find themselves in an environment such as this. Notice the individual bed. Notice the equipment around that child, ready to serve every need, every technology possible is right there. There's over $100,000 worth of equipment shown in this picture. 12 feet away, all of that equipment is repeated for the next child. Take really close note of the piece of equipment there that has 6 dials. It's a ventilator. Ventilators cost between $25,000 and $40,000. And they address one of the most significant challenges for newborns, particularly premature babies, respiratory issues. Just keep that in mind. Contrast this with the neonatal unit at Queen Elizabeth Central Hospital. This is 10 babies, shown 5 in the first isolate and 5 behind. Those 10 babies are sharing oxygen from one oxygen concentrator. 5 of them can get oxygen at a time in that environment. It's not uncommon for there to be 2 nurses and 50, 60, or 70 babies to be taken care of by those 2 nurses. These are the sickest children. Liz talked to us about some of the major challenges that these children face. Premature babies. 3 million children die worldwide in the first month of life. Over 3 million. Half of those die from respiratory-related diseases. 99% of those deaths are in environments such as this in the developing world. She challenged us to have our students, to work with our students, to develop a technology that would help deal with the respiratory issues so that we could save some of those babies. She challenged us to design from the ground up a technology that was not only highly effective, but low cost, robust, and really designed for that environment. And in particular, she wanted it to be either repairable easily by the technicians that they had on site, or just simply not break at all. So when we returned and posed the challenge to our students, we looked at the literature, and there was a really nice paper published a couple of years ago by Kamath et al. That looked at respiratory distress syndrome in the United States. So in the United States, and they looked at treatments and survival over time. So in the United States, in the early 1900s, there was no treatment for respiratory distress syndrome. Respiratory distress syndrome occurs in many premature babies when their lungs are not fully developed and they collapse between breaths. So those babies, every single breath, they're able to breathe on their own, but they have to expend all this energy to open their lungs up and then take a breath. And then when they exhale, their lungs collapse all over again. That is so much energy. So rather than growing and eating and being able to heal their diseased lungs, they spend all of their energy trying to breathe, and in a few days, they wear out. So in the early 1900s, there was no treatment for respiratory distress syndrome. And in the United States, pretty much all of the babies with respiratory distress died. Then in the 30s and 40s, 1930s and 40s, we started being able to provide nasal oxygen to these babies. Once this happened in the United States, about 25% of those babies were able to survive. And then in the late 70s and early 80s, Cpap was introduced. And the survival rate jumped to 70%. Cpap is continuous positive airway pressure. What you do with Cpap is you deliver pressurized air into the nostrils of a baby, and it essentially holds the baby's lungs open between their breaths. So now what the baby has to do is simply a regular breath rather than having to pull their lungs open and then breathe. Think of this as like when you blow up a balloon. Some of the students, you were blowing up lots of balloons last night? Yes? So the first couple of blows are really tough. But once you get past that initial opening, the next blows are easier. So this baby now can have pressurized air coming into their lungs. The lungs are open, ready for them to take a regular breath. While they do that, their lungs are able to heal and mature. They're not spending all of their energy just trying to take a basic breath. So remember this picture. The current standard of care right now, 2013, in Malawi and in most of the world, is nasal oxygen. Cpap is known to help, but it's simply not available in these countries. The technology can either cost over $6,000 or require oxygen and air to come out of the wall, which is definitely not going to the situation in most of the places we go. What we wanted to do is develop a technology that would take us to this much higher survival rate. Develop a Cpap system that would work in their environment. So a team of bioengineering and global health technology students working at our design kitchen at Rice developed this technology. And what you're looking at is actually a plastic shoebox. It really is a plastic shoebox from Target, I think, that has a bubble Cpap system embedded in it. I'll get a little bit better picture of this system. The genius of the system is that the pumps that deliver the air to the baby are aquarium pumps. Aquarium pumps are designed to run continuously for years on end and not break. This is what they need to be able to do in the developing world. If they break, it's a diaphragm, a simple diaphragm. If that rips, you have to replace it, but it's less than $1. And you unscrew the pump and you pop a new diaphragm on and it will work from there on out. So that was a really clever potential solution. They used a bottle of water. This is something that's very commonly used here in the US. They used a bottle of water where you put your tube down into the bottle of water, and the pressure you deliver is however much water is beyond the end of your tube. And so it's a pressure relief valve that's incredibly inexpensive, and it's easy to make. You fill water in a bottle. So really simple. So this took the technology from being a commercially available $6,000 or $8,000 device, and this cost us $150 to make. So the first thing we tell our students to do is actually design your device, build it, and then test it and make sure it does what it should do. So what they did was they went to Texas Children's Hospital and they measured pressures and flow rates out of a bubble Cpap system used in Houston with babies that are premature. And they compared that to the pressures and flows that we got from our system. And what they found was really comparable results. These were wonderful results because what we were able to show is that this $150 device was able to deliver equivalent flows and pressures for the air to the nasal prongs that were going into the baby. So this gave us some really good incentive to go further. The next thing that was done is that Jocelyn Brown, one of the students, you saw her a few pictures ago, who designed the technology, was able to take the technology to Rwanda, to Malawi, to many other countries, and demonstrate it to nurses and doctors. She was able in Malawi to leave it there, and they evaluated it long term, really tried to see what worked with it, what didn't work. And we got incredibly valuable feedback. You know, that plastic box has to go, it breaks, or if it hasn't already broken, it will break really soon. The tubing connectors, the nurses had trouble making sure they were connecting the right tubing to the right port. So this was feedback that was absolutely essential in order to be able to move this project forward. She returned to Rice and redesigned the technology. The engineering and the materials inside are actually essentially the same, but where different connectors are changed. It's very well labeled now which tube is supposed to go to the baby and which tube goes to the water bottle. And in fact, all of the connectors are polarized, so you cannot plug the wrong tube into the wrong port. And with this iteration, we were ready then to do a true clinical trial of the technology. So this picture is a picture that makes me really happy. It's the very first day of training of our Cpap nurses at Queen Elizabeth Central Hospital, where we undertook the clinical trial. And the training was a 3-day training, and this was the first morning. And that first morning, we taught all of these nurses how to set up the system, how to put the interface on a baby. And so by the time noon came around, they were getting really comfortable with the technology. But remember, this was a 3-day training. Well, immediately after lunch, we got a phone call from a doctor in the emergency room. And he said, "I know you're only 4 hours into your training, but I have a sick, sick baby." The baby was 6 months old, was suffering from bronchiolitis, really having a hard time breathing, and was wearing out. Her oxygen saturations were in the 60s. She was completely unresponsive to her mother or anyone else. Normal oxygen saturations are in the 90s or high 90s. This was an extremely dangerous situation for the baby. Well, of course, we were going to be ready. And so they took the baby to the intensive care area. We took one of the Cpaps and the oxygen concentrators and all the other things we needed. And all 4 nurses got to participate in putting that first child on Cpap. Within 5 minutes, that child's oxygen saturations were in the 90s. Within an hour, that child was interacting with her mother. In 5 hours, she was nursing. In 5.5 days, she went home healthy. An amazing thing to see. This is a picture of a baby in our clinical trial. This is a neonate. And what you can see in the picture is this baby is resting really calmly. What you don't see in this picture, and what we really can't show in a picture, is how this baby looked before Cpap went on. The retractions of her stomach to try to open up the lungs, real stress. But when the Cpap system goes on, the baby relaxes, they're able to breathe, they're able to rest, they're able to heal. So we've completed the clinical trial. And what I show here on the left is that graph I showed you initially in the history of the introduction of technologies in the US. And here on the right, we show the results from our clinical trial. The red bar is babies who received nasal oxygen. 23.5% of those babies survived, very comparable to what we saw in the United States. Remember, that's the standard of care right now in Malawi and in most places in the world. Those babies that received bubble Cpap, their survival was 64.6%. To put this in perspective, that means for every 100 children that have access to Cpap, 40 of them will survive because they have access to Cpap. This is a remarkable increase in survival, and it is exactly as expected based on the historical data in the United States. So this is the country of Malawi. I meant to look up the dimensions. It's between 80 and 140 kilometers wide. and quite long. And where the star is our initial trial at Queen Elizabeth Central Hospital. So we have used that trial to ensure that the equipment is robust, to make sure that it is helpful, that it indeed, in that environment with the nursing care and the number of babies in the ward, that in that environment it will have the desired effect. And this has been quite positive. Over the next year, we're rolling out the technology into all of the other central hospitals in Malawi, as well as 4 of the district hospitals in the regions of those central hospitals. After this year, the plan is to expand over the next 2 years to 28 government hospitals in the country of Malawi. So what I've shown you are, in some sense, raw data and graphs and maps of where we're going to go. And I think this is really important information. But the next picture I'm going to show you is actually what I think is the most important part of this project. When we went to one of the district hospitals that we were doing a baseline training, collecting initial data for what their survival rates are in these various sites, we walked into the maternity ward to tour and to take a look at where the Cpaps might be set up. And a nurse came up to our doctor partner, Dr. Kawaza, and said, this nurse that's hiding behind her baby, she said, you probably don't remember me, but my baby was in your trial 5 months ago. So we talked and we learned that her baby was thriving, doing incredibly well. And I just sort of from the side of my mouth said, I'd love to see your baby. And she said, my baby's a block away. I'm going to go get my baby. So she went and got her baby and brought the baby back. A beautiful picture of a healthy baby. That mother behind is smiling. But there's more to this picture. Jocelyn, the student who designed this technology, who graduated at 21, is now living in Malawi, leading the effort to scale up the technology countrywide. And a new partner, Norman Lufesi, who works for the Ministry of Health in Malawi. We made the decision that we wanted to go into all of the government hospitals, and we wanted to do this with and through the government. Norman has spent his career working on respiratory issues of children, and he is spearheading the way for us to be able to get into all of these hospitals. And I look at the happiness and the joy in all of these faces, and I feel like this is the picture of what Cpap is doing in a country like Malawi and what it can do all around the world. This is another picture that we really enjoyed receiving. This is the new Pumani machine. Pumani means breathe easy in Chichewa, and the nurses named it for us. And this is the first 6 units off the production line. We are now in the process of completing production of all of the Cpap units that will be needed for the entire country of Malawi. So it's really exciting to see a very professional device. It's been redesigned a little bit based on the feedback from the previous device. I don't know, engineers never stop redesigning or something. And what I'm going to do is just take a minute to demonstrate the technology to show you really how simple it is. So here is our Pumani. What I've done is I've put water in the tube, and the water needs to be somewhere between 5 and 7 centimeters high. And if I'm going to set up a baby on Cpap, I connect the tubing to the water bottle, and then the water bottle tubing to its appropriate location. This is tubing that goes to the baby. I connect it to my little baby place, and I turn it on. I have the option of setting the flow rate. If I want to add oxygen, I connect it here, and I can add the proportion of oxygen by changing this regulator. And if you notice, when I connect this to the baby, it's not actually connected. When I connect it to the baby, some of you in the front row may see that the water is bubbling. So there you go. And what happens is that when the system is working, the water will be bubbling. if the prongs fall out of the baby's nose, the water stops bubbling. So that bubbling is the pressure relief, and it maintains the appropriate pressure. But it's also a great symbol to the nurses or the parents that the system is working. So there's a quick alert if something is not right. Our plan is to go to all hospitals in Malawi, and if things go well and we can figure out how to do it, all hospitals in southern Africa, and then, in truth, everywhere that infants need help with breathing.
So Bubbles Cpap addresses one of the major needs to help newborns survive, but it doesn't address all of the needs to improve newborn survival. When we thought about it as a team, what was needed, we realized that there were really 6 things that you need to help keep newborns healthy. You need to keep them warm, you need to deliver IV fluids safely, you need to monitor their vital signs, provide them with help if they have respiratory issues, identify and manage their infections, and treat jaundice. And if you could develop affordable, effective technologies to address those 6 things, you could do so much to reduce the 3 million neonates that die every year. We've been working with the team at Queen Elizabeth Central Hospital to develop a comprehensive set of technologies to meet this need. And shown in this picture is an incubator to help keep babies warm that's appropriate for low-resource settings. And this is not an innovation from our program. It's an innovation that the team in Malawi developed and used. It's called the Malawi Hot Cot. It's a wooden crib that uses 4 incandescent light bulbs to warm the air in the crib. Nurses monitor the temperature using a garden thermometer, and they turn bulbs on and off to control the temperature of the incubator. And in the neonatal unit at QECH, there are about 25 Malawi Hot Cots keeping all of the premature babies warm. They did not have the ability to provide phototherapy to babies who suffer from neonatal jaundice, and when their serum bilirubin levels get too high, it can cause severe brain damage in infants. Phototherapy lights cost about $3,000, and they had only a single set of phototherapy lights at Queen Elizabeth Central Hospital. And so Dr. Molyneux tasked us with having our student teams design a low-cost set of phototherapy lights. And you can see in the photo and here a set of phototherapy lights that was built using blue LEDs. And in contrast to the $3,000 that's required for the commercially available lights, these lights can be manufactured for about $100 a set. We carried out a clinical study of the efficacy of these lights in Guatemala, and what we found was that they were equally effective as fluorescent or halogen lights in reducing serum bilirubin levels. And at QECH, they now have about a dozen sets of these LED-based phototherapy lights that are used routinely to treat neonates who suffer from jaundice. Monitoring vital signs is another big challenge, and especially with premature babies, because their nervous systems are immature, sometimes they forget to breathe, and they can die as a result of these apneic episodes. In the States, we would monitor their respiratory rate, and then if a baby stopped breathing, it's a very simple treatment. The nurse just comes up to the baby and rubs its back very vigorously to stimulate it enough to begin breathing. But they don't have vital signs monitors, again, at QECH because they cost a couple $1,000s. So we had a team of students who designed a sensor that not only detects apnea, but corrects apnea. I've just turned it on, and there's a stretch-sensitive resistor, which every time I stretch, you can see that blue light going on. It's detecting a breath. If I stop breathing, in about 20 seconds, there's a coin-sized vibrating motor inside here, and that motor will start to vibrate. It's like your cell phone on vibrate. And the force associated with that is quite comparable to what a nurse provides to stimulate. It's just gone off here. Now, if I don't start breathing again, this red LED is going to start flashing to alert the nurse that she needs to come over. But if I start to breathe again, the motor and the light go off. These can be made for about $20, and they can run for about 2 weeks on a single charge of the rechargeable battery. If we want to identify and manage neonatal infections, in many hospitals in the developing world, there's very poor access to laboratory testing, and things like blood culture simply aren't available. Being able to simply have access to a complete blood count at the point of care would be transformative in this setting. And so our students have worked to develop very simple optical technologies to be able to monitor hemoglobin. I pricked my finger before you all came in and dropped a spot of blood on this piece of paper. And this little $10 reader that has been designed to measure the transmission through the paper will measure the transmission in the red and green regions of the spectrum, and will display the hemoglobin concentration. And it's gone up. I'm not at a hemoglobin of 21. It goes up as it dries. You typically need to measure it within about 10 minutes of pricking your finger. But then similar technology, this is a low-cost fluorescent microscope that can be used to measure the concentration of white blood cells and to do a differential to help provide the CBC information to manage those infections. But I think the most important thing is to bring together this comprehensive set of technologies so that clinicians in this environment can manage these premature babies effectively. And this is a photo taken again at Queen Elizabeth Central Hospital where you see one baby who's in that Malawi Hot Cot being kept warm by the hot cot. Baby has breathing difficulties, so he's being treated with Cpap. You can see the Cpap system up there on the shelf. And the baby has jaundice. He's receiving phototherapy with the set of phototherapy lights. And those are not lights, actually, that were made at Rice. Those are lights that were made at Malawi Polytechnic College, which is located right across the street from Queen Elizabeth Central Hospital. So we're engaging engineers in the local community to begin to manufacture and to continue to innovate these types of technologies. We're so honored tonight to be here representing everyone at Rice and around the world who has contributed to the development of these technologies and to assembling what we refer to as the Nursery of the Future. And when we first got the news that we were to receive this prize, we talked about what we wanted to do with it. And we really wanted to multiply the impact of the prize for neonates in Malawi and in other poor countries. And so we've decided to donate our prize to be used to build a new neonatal ward at Queen Elizabeth Central Hospital. It's our hope that this will be the first step toward establishing a site where not only these very vulnerable babies can receive the highest quality care, but that it can serve as an innovation hub for the continued development and translation of these technologies. We estimate that other nurseries of the future could be established at district hospitals for a total cost of only $5,000. And that's significantly less than the cost of just one Western-style ventilator. At the end of the day, I think when students have the opportunity to see both the successes and the failures of technology innovation, they really grow as leaders. They become the kind of leaders who realize it's not okay if 3 million babies die of preventable causes every year. I want to end with a quote from one of our students, Christina Lagos, who traveled to Lesotho early in our program. And when she came back, she wrote, "I have seen the struggling face of a baby who died of a simple case of diarrheal infection, and the face of her mother who thought her child was on her way to improvement. I've seen the determined faces of a medical team that went to great lengths to take a child to a South African hospital to put a baby on a life-saving ventilator, a simple tool they lacked in Lesotho. I will leave with a more inspired opinion of what I can do as an individual, what the limit of that is, and what the potential of that is." Thank you.
We're happy to take a few questions right now if you have any. Yes?
Have you gotten any feedback about just how far your 100,000 will go in an economy like that to build?
Yes.
The total project cost to establish the nursery is about $375,000. And we've made some significant progress toward raising the funds that are necessary for the project, but we still have a ways to go.
Yes?
What advice do you have for inventors or innovators who'd like to aid projects in underdeveloped countries?
So I think there are a number of things that come to my mind. First, understand the environment you're working in. Find partners that are willing to tell you what you don't want to hear. If you go somewhere for the first time and you don't have a relationship with people, what we've found is that often they will like everything you show them, and they won't tell you what they really think. And so establishing long-term relationships with people where you develop a trusting relationship is critically important. None of these problems are solved by one person, so you need to work with a team and pull in additional team members as needed for the projects. There are a number of lessons, I think, that you go, and the final thing I think I would say is partners. So there are other people who have great experience implementing things in countries. So go to those countries that you want to work in and find the people that are already doing that sort of work and partner with them, because you're going to get through the barriers much more quickly. Yes?
I know there are a lot of African countries that resist Western intervention. Have you received any resistance from governments in Malawi and sort of other African countries trying to help?
And so I think on the part of the clinical team, both the Malawian team and the Cpap faculty that are working there, we have had just an amazing reception and a willingness to partner together. We have encountered in the Cpap project, one barrier that we didn't expect, and that is that mothers are often quite fearful to have tubes put in their baby's nose. And the reason for that is often a child is brought to the emergency room struggling to breathe, literally moments away from death. And even though everyone at the hospital knows that offering oxygen probably isn't enough to make a difference, it's the only thing they have to offer. And so many people associate the use of oxygen with death. And that has been something that we've had to overcome. And what we have found is that when a mother sees how much their baby settles down and is more comfortable on Cpap, then she becomes the biggest advocate for that technology with other mothers who are similarly reluctant.
I would add one thing in addition to that is that we have been greeted with people being quite interested in what we're doing, but until we have returned several times and have actually done what we say we're going to do, we haven't yet built the trust. And so I think it's incumbent on those of us that want to go other places to realize that we're going to their home and not to promise things that can't be delivered, and to be consistent and to be partners, not somebody coming in to solve their problem, right? We work together with them to solve the problem. And I think it's a slight difference in attitude and perspective, but it's very important.
Could you explain the surfactant with the 85% survival rate?
Sure. So there is something called surfactant that can be added to babies' lungs that actually help hold the alveoli open. So the challenge with surfactant, so you can jump from the 70% to 85% survival. The challenge with surfactant is that it requires someone to be intubated and in many cases to have access to a ventilator. It's quite expensive, although the cost has gone down a lot. But being able, when we mentioned that, we asked our partner, well, what about surfactant? Could you just use surfactant and forget Cpap? And she just said that it was just impossible without a higher level of potential care and without having the ventilators, many of them. This hospital we work in is the teaching hospital in Malawi, and they have just one ventilator in their surgical suite. So it just wouldn't be feasible, although it's a wonderful technology and is used in the States and in other developed places.
For your Cpap, does that have to have filtered water in the water bottle, or can it just be water from the tap?
So you want it to be clean if you can, but it's the air that's going to the baby is not actually going through that water bottle. So sometimes people put a drop of chlorine in it if they're concerned about it being clean water. But that concern about infection is one of the things. Many commercial Cpap systems actually have a humidification. And if you're going to add humidification to the air, that water needs to be clean. And we did not include humidification. We changed the treatment a little bit and used nasal saline drops because we were quite concerned about introducing infection to a baby's lungs. There's a question over there.
Oh, sorry. On a broader note, what other countries do you foresee yourselves reaching out to in addition to Malawi?
So we're actively talking with neonatologists in South Africa about providing Cpap in rural areas of South Africa, also talking with neonatologists in Kenya. We've been doing work in Lesotho, in Botswana, and in Swaziland, mostly in the southern part of the continent. The needs are so similar, though. Once you get outside of South Africa, the needs in the southern region are all quite similar.
I'm just super inspired by your team's ingenuity, but I was so struck by the slide where you talked about how that device in America is $6,000. And I guess one of my takeaways was just that Western medical devices are overpriced. Have you thought about what this kind of work could do in terms of just lowering the cost of healthcare? It seems like if you're getting comparable results for an order of magnitude less, that someone's making a fortune on it.
I think there's sort of two issues that are at work there. One is that there are often fail-safes that are built into devices to satisfy regulatory requirements in the United States. And those fail-safe mechanisms often mean that those devices don't work or are unsafe to use in the developing world because the quality of the line voltage may not be appropriate or the quality of the water may not be appropriate. And so removing them makes them work better in the developing world, and it also makes them less expensive. But for some technologies, I think exactly the same approach could be used in a low or high resource setting, like the hemoglobin testing. The accuracy is quite similar to the standard of care for point-of-care hemoglobin detection that's used here today, and you could reduce costs by at least 100-fold, we think. And so we're quite interested in the dual market applications where they make sense.
There's a question up here in the middle. That's you.
You talked about, I think, 6 major ways that you can help babies survive. You talked about 6 major ways where you can help babies survive. Will you personally also be looking into the other methods, or will you leave that to someone else?
We're interested in looking at, in this particular program, any technology and all of the technologies that would be needed to address the major health concerns of that particular population. So we're working in some ways on all fronts there. So for example, the Malawi Hot Cot, it is a great technology for the particular ward that it's in. And that's because they have a really excellent method for monitoring. Even though it's manual and nurses have to do it, they do it very effectively. So that means that they make sure the babies don't get too warm. But when that technology has been taken to other hospitals where the nurses are even more overworked and they're not used to checking for the temperature, that manual method breaks down. So we think the best incubator has not yet been designed. And I've offered that as a design project for 2 years. We have several failures now to show the next groups. And I'm hoping that next year another team will pick that up, because I think that's one very big key. And we're going to keep working on those technologies until we have them all.
I was just wondering if you run into problems with the infrastructure of electricity, and even with hospitals that don't have electricity. I noticed that you have a battery on one of the devices, but I was wondering if same.
So, I'll talk for a second about Cpap. So it is a device that is plugged in. I guess you could have a backup battery and make that work, but it does need power. And power is very spotty in some of the places that we're working. In many of the neonatal wards, they might have a backup generator. But one of the things that's happened that we've noticed in the course of our trial is that we put CPAPs in place at the hospital. We also put oxygen concentrators in place at those hospitals to support these CPAPs. And they've been running now for 18 months at the Queen Elizabeth Central Hospital. And despite all of the crazy line voltage and despite power outages, the CPAPs have continued to work because they have no digital electronics. It's all analog. I mean, really an on-off button and power to the pumps. That's it. Whereas the oxygen concentrators, we have failure after failure because the digital electronics gets fried. So we have problems in that way. There is concern for district hospitals if they don't have access to power. Obviously, something like this would not work in that environment.
I'm told we have time for one last question.
You earlier spoke about how it was important to gain the trust of the people you were working with before they were going to be welcoming to the new technologies. I'm wondering if, with all the countries that you have been visiting, if you're starting to get any kind of a reputation, if you're noticing any, like, a tipping point where people have heard of you and they're already welcoming the technology when you get there.
With Cpap, we're starting to see that, but I think it's less reputational, and I think it's more based on data. Now that we have data showing that it can make a really significant improvement in survival, people are now starting to come to us to say, we'd like to have this technology in our setting. That aside, though, I'll say, our experience has been it takes about 4 visits to sort of get to the point where people believe that you're going to continue to come back and listen to them, because you're not the first girls to show up with gadgets. So. Great. Thank you.
Thank you very much.
Yeah, that was really great. Let's thank Rebecca and Maria one more time. That was very inspiring. So we continue tomorrow, of course. We have a lot of activities tomorrow, and then tomorrow night we're going to have another celebration like this for the Lemelson-MIT Prize. Please join us again tomorrow night. And thank you for attending tonight, and have a good evening. Thanks.